Welcome back to Two Things. I'm Peter Dunn, Vice President for Capacity and one of the co-leaders of the Capacity Coordination Center. I'm joined by Ali Raja, the Deputy Chair of Emergency Medicine, Donna McEachern, Nursing Director for Capacity and Nursing Supervisors and co-leader of the Capacity Coordination Center, and Ben Orcutt, leader of Patient Access and Capacity Center, co-leader as well. We've heard a lot of questions about what does it mean when we hear about these capacity alerts. We're hearing them a lot. So I'm asking Ali, what do they mean?
Peter, we have 3 different capacity levels outside of our standard practice, our daily practice. The first is called pre-code help. And pre-code help is reached when we have all of the bays in the emergency department full, and on top of that, we have half of the monitored hallway spots full. Now, when things get really busy, we can put patients into places that aren't monitored, chairs and hallway stretchers where there are no monitors. But we want to start activating the thresholds for capacity levels when we start filling up our monitored areas. So pre-code help is half of the monitored hallways in all of the rooms. Code help is when we have all of the rooms and all of the monitored hallway spots full. So every monitored place that we can place a patient, we've filled with patients. And at that point, we call code help. Now, after code help, we can start building up the number of patients who are boarding in the emergency department to go upstairs to a room bed. When that happens, if we get to the point where we have more than 35 patients, we're talking about an inpatient unit's worth of patients boarding in the emergency department. When we get to that point, we activate a capacity border protocol where 5 patients automatically go up to inpatient units without any sort of special trigger. But when we get to a point where we have 45 patients boarding in the emergency department, waiting for inpatient beds that haven't been assigned beds, that's when we call a capacity disaster. We'll talk more about that in a minute, but realize that we don't get to that threshold until we have 45 patients waiting in the emergency department to go upstairs.
Ali, thank you. So the problem's not just within the ED, it's actually a hospital capacity challenge. So Ben, what is it that the Capacity Coordination Center does in response to these capacity alerts?
Perfect, thanks Peter, and thanks for describing that, Ali. It's really important for our team and others to get those alerts so we all know the status in the emergency department, and we'll snap into action and work with the units. The Capacity Coordination Center consists of the Capacity MD, the access nurse, the nursing supervisors, and the admitting team, and we work together to both get identify and get patients up to those auxiliary spots in both the code help and the capacity disaster status, as well as to free up any beds that may be closed that we can open somehow with infection control. We work with nursing, we work with police and security to open up those beds and expedite any movement up to the inpatient units and provide relief for the emergency department, the PACU, other portals of entry where patients need to get to Mass General. We work very, very closely with the nursing supervisors on movements out of the ICU and prioritizing patients that need to get there for their acute needs.
Okay, Ben, thank you. And Donna, in your role as a nursing director, what is it that you work with on the floors to help do a lot of the things Ben just described?
Great, thank you both. So when the hospital is in capacity disaster, the inpatient units are really integral to our response. They set up 28 auxiliary spaces in a variety of units. Our environmental services departments set these spaces up. The spaces can be in places like a hallway, but they also are in visitor lounges, sometimes an OT or PT room, sometimes in an infusion room. And so setting up these spaces does cause strain on the inpatient units, but they're very aware that responding to the emergency department's congestion is really vital to our being able to take care of patients well. Other things that happen on a daily basis are, the nursing supervisors work closely with the inpatient unit leadership to facilitate throughput. They are working with the nursing directors and others to open beds that may be closed. The nursing directors are reaching out to case management and attending nurses to try to identify patients who may have a barrier to discharge and to prioritize patients whose discharge is very time sensitive, such as patients going to home hospice or to our home hospital program or to nursing homes, because those are very time sensitive. And so working together, we can help to respond to the emergency department, and it really takes the entire hospital's efforts to do so.
Thank you, Donna. So it certainly is a hospital-wide effort to address the challenges there. The ED is just a lens into the capacity that we're facing. So, and it has a lot of impact. So, Ollie, on the days where we do see, a benefit from that, what are the de-escalation pathways that are in place?
It's a great question, Peter, especially because I know that a lot of people watching this video see the pages as we escalate, but don't understand how frequently and how often we de-escalate. And the same thresholds that we use to activate, when we reach those on the reverse side, so on a day where we might have 65 or 70 patients boarding to go upstairs, when we reach that capacity disaster threshold of 45, we reevaluate things and we start de-escalating. We have a built-in buffer of time between each stage to allow us to have a chance for the hospital to recover before we return to normal operations, but we de-escalate readily. We just don't page that out as broadly as we do when we escalate.
Great. Thank you all.